Martha, sorry to interrupt. I don't know if you can hear us, but I think you're muted, so we can't hear what you guys are saying. If you don't mind unmuting, please. Thank you. Thank you. Did you hear me? No. Oh, anybody? Okay. Oh, no, I thought you said you. Oh, I was okay.
Okay, I think it's working now, Ivan. All right. So hypercoagulability. So any condition a patient has that causes their clotting cascade or clotting function to overwork. It's like malignancy, inherited diseases that cause thrombophilia, pregnancy, oral contraceptives that has estrogen, inflammation, infection, nephrotic syndrome. Why do we have increased coagulation function in nephrotic syndrome?
Increased loss in the urine that makes it.
Good. And then the endothelial injury. So surgery, trauma, central veins, actually any damage to the veins. And then the venous stasis. What does it mean? What does venous stasis mean? So stasis means not slowing, maybe slowing, but stasis means, from what I understand, is that something that's sitting in the same place. That's stasis. So blood, sitting in the same place or slowly flowing, that's just gonna give more risk to develop the VTE. Then provoked versus non-provoked, unprovoked. Why does this matter? Why does provoked versus unprovoked matter? Treatment duration. So what's the treatment duration for if it's provoked? Okay. And what if it's unprovoked? Sometimes indefinitely, sometimes like forever, right? Okay. So also there are categories like major transient, minor transient. I don't really want to go into these details. This is all based from the AHA, ACC guidelines. Then you have the inherited and acquired thrombophilia. You have the mild forms, the higher risk, and the acquired forms. So you have factor V Leiden. You have the antithrombin deficiency, protein C and protein S deficiency. And then you have the antiphospholipid syndrome. Then we talk about the diagnosis, right? So when you think about diagnosis in general, you think about probability and then you test. You never test first. If someone who's 25 years old, completely healthy, comes in with dyspnea, really, so they don't have any risk factors, nothing. Their Wells score is very low. Their probability is like 5%. Okay, so you might go to a D-dimer. You don't really have to go to a CTPE like they do in the ED, right? So everyone comes in like with a mild chest pain, they do CTPE, or any person with shortness of breath, they do CTPE. So this is called defensive medicine. This is not the true medicine. This is the true medicine. So the clinical presentation first. So if someone comes to you with unilateral leg swelling, pain, erythema, tenderness, and like sometimes you see a cord, then sometimes there's something called Homan's sign. What is Homan's sign? So this is Homan's sign. So you do dorsiflexion of the foot, and that might elect pain. Okay. So what's the thing about Homan's sign? I mean, doctors will have a lot of signs. You have the million signs of million diseases, right? But does it really rule in or out? No, it's not sensitive and not specific. And then you have the third red one. I don't know how to say it. Phlegmasia, cerolia, dolens. So basically, this is what you need to care about. This is a limb-threatening emergency. So when you see something like this, not this, this. So when you see something like this is an emergent consult to vascular surgery, emergent initiation of heparin drip, because if you don't act, the patient's going to lose their limb. So the PE symptoms and signs: tachycardia, dyspnea, cough, hemoptysis, sometimes hypotension if they are really massive. What are some ECG signs that you might see on the ECG for a patient coming in with PE? So sinus tachycardia. What about the classic finding that we study in medicine? Of course. I have never seen one. It's very rare. You don't really see it that much. Also, it's not sensitive or specific. Great. Yeah. So this patient comes in, shortness of breath, chest pain, localized chest pain. This guy has, let's say, cancer, comes in with this presentation. And then you do a CTPE because their risk is high. Then you find this report. So acute right lower lobe segmental and subsegmental pulmonary emboli and peripheral wedge-shaped right lower lobe pulmonary infarction. Remember this sign, Hampton sign, Hampton lump, hump, seen on chest radiograph. So this is it. If you see this here, the triangle-shaped thing, the cone-shaped thing. So this is the Hampton hump. And then sometimes same patient comes in with the same presentation. You do a chest X-ray, and then the reading for the chest X-ray is like this: regional oligemia of the right lung consistent with Westermark. So what does it mean, Westermark? What does this sign mean? It means that the pulmonary artery is blocked, correct? So there's no blood going further than the blockage side. So you will have less, you see these white things here? These are the arteries, right? So if you have oligemia, it means that just lucency, the black area here, that's the Westermark sign. And this is the famous S1Q3T3. It's the second one. So you have the S wave, on lead 1, and then you have the Q wave on lead 3, and the inverted T wave on lead 3 as well. And you have the sinus tachycardia, you have the right bundle branch block, you have the anterior T wave invergence. So you have multiple signs that you can see on the EKG, but none of them are actually going to be diagnostic. Okay, so now we're going to talk about some test scoring systems. So the pretest probability comes first. It decides whether you're going to go to a D-dimer or you're going to go to a CTPE. So it rules out. It never rules in. So if you have a low pretest probability, negative D-dimer, it rules out because it's very sensitive. Okay, so only useful if you have low or intermediate risk. And if you're having a high suspicion, despite all of this is negative, then you start empiric anticoagulation. You don't wait. So the Wilson score, it has 1, 2, 3, 6, so I think 9 points. So if it's at least 2 for a patient presenting with leg swelling, then you do a compression ultrasound. If it's 1 or less, then you do a D-dimer. For the PE, it's kind of the same thing, but instead of the 1 and 2, you do 4, and instead of the compression ultrasound, you do the CTPE. And then you have the PERC. I only use it like as perk. I don't really memorize what does it stand for. But you can rule out DVT, PE without even ordering a D-dimer. However, there's one downside for this. If one of these 8 points is positive, this is not useful. Like, you cannot rule out. But if all of them are negative, you don't really need to order D-dimer or CTPE. So you have age less than 50, heart rate less than 100, saturating more than 95% on room air, no hemoptysis, no estrogen, no prior PE or DVT, no swelling, no surgery or trauma within the last 4 weeks. So, and this is the diagnostic pathway. So if you're suspecting lower extremity DVT, you go for Wells DVT score. If it's 1 or less, then you go for a D-dimer. If it's positive, you go to a compression ultrasound or whole leg ultrasound. And then you take it from there and you decide the diagnosis and treatment. And the imaging modalities. So we have the CTPE, VQ scan, compression ultrasound, and echocardiography. Echo. Why do we need echo? Why is it important? Level of care. If you have right ventricular strain, then you need a close monitoring and sometimes ICU level of monitoring. Of course, our ICU is not going to take those patients because they're stable. Also, we're going to discuss something that's very important that's emerging very recently. It's called normotensive shock. You have shock, your MAP is above 65. No matter if you give fluids, whatever, if you have lactic acid that's high, it's type A lactic acid, means hypoperfusion, even though that your MAP is above 65, it's called normotensive shock. So the CTPE is the first line imaging modality for PE. These are all information that you guys know. So I'm just gonna talk about the caveats, the things that are gonna be actually useful in your everyday work. The VQ scan is used when you cannot use CTPE. Let's say a pregnant patient, let's say a patient with ESRD. Actually, no, if the patient is on ESRD, you don't really care. They're already on dialysis sometimes. You just like go for CTPE. Compression ultrasound and the echocardiograph. So this is the, do you guys see it or no? Can you see it? So let's see. Yes, thank you, man. Appreciate it. All right. Oh, thank you, Dr. Ansakal. So this is a normal VQ scan. So basically, there are like 4 phases. I'm not going to go into the technical stuff, but you will see balanced perfusion and ventilation. You won't see like mismatch. When you see mismatch, it gives you a probability, low, intermediate, or high. It doesn't tell you, oh, there's no PE. No, that's not what you're going to get from the report. It only tells you low, intermediate, or high risk. And then I have something else to show you guys here that you're going to like. And Dr. Hadid will like so much. The focus. So we already, I think we already have, oh, it's not showing. Okay. So look at this, guys. What do you see here? It's very obvious, right? Okay, so you did this. Let's say it was negative. What do? Does it rule out DVT? No, it does not. You need to repeat it in a week to 100% confirm that there was no DVT. Okay, is this clear for you guys? You see the vein, and you see the hyperechoic shadow here, like hyperechoic thing here. That's the embolism, the thrombus. Yeah, I think they are compressing the skin. They're trying to compress it, but it's not getting compressed. Okay. All right. One more thing I wanted to show you. Always look at your imaging. Okay. It's nice that you're going to read the report, but always look at your imaging. So I'm just going to go walk you guys through this as well. Have you guys, do you know about Radiopedia? This is a very, very nice website. So, okay. See this? That's PE. This is what you see if it's visible enough. And I think there was some other stuff, but it's okay. We don't really have the time. All right. Okay. So diagnosis and pregnancy usually go to VQ scan right away. Okay. Risk stratification. So how sick is the patient with PE? So this is where the RV function comes in. So the classification, this is, I think, the European guidelines. They have vocabulary for themselves. By the way, European guidelines are the best in cardiovascular medicine. They're, I think, 5 years ahead of the American guidelines. We're in America, we're just starting approving what they already approved 5 years ago. So you have the high risk, which is the massive PE, and then you have the submassive PE, and then you have the intermediate low, and then you have the low. So how do you guys differentiate? The RV dysfunction, it's present if it's massive or submassive. And also the hemodynamics. If the patient is hypotensive, then this is 100% massive. All right, if the patient is normotensive, it's the rest. So blood pressure does not really tell you how sick the patient is. And then you have the biomarker. So if you have RV strain, you will definitely have troponins, you'll definitely have BNP. All right, so you have the prognostic scores. Who can go home? Of course, someone with high score. I'm not gonna, go inside like all of these scores, but you'll see this sometimes with pulmonary notes or vascular notes. If someone has a high score in the prognostic scores, they probably need a lot of care. Okay, so now we have the acute PE clinical categories, which is the most recent one. We just make everything complicated. A and B you don't really care about because they're like subclinical, asymptomatic, sometimes symptomatic, but it's very low risk. So we only care about the sick ones, who are the C, D, and E. And of course, we have stage A, B, C, D in cardiology, heart failure. You have NYHA. Then you will have C1, C2, C3. You will have D1, D2, D3. And then you have E1 and E2, I think. There's no D3. But this is, what is it? So once you have a patient in C category, you will have a normal right ventricle function. That's C1. If you have abnormal right ventricular function and at least one biomarker abnormality, then C2, and then goes on, C3, and then D1, then D2, then E1, then E2. So once you reach E2, what is the treatment here? It won't be, once you reach E2, despite everything that you did, when the patient, no, you already did it when the patient was in transient hypotension, let's say. ECMO, yeah, ECMO, because the lungs are not working, so you need ECMO. And the heart is not working too. All right, so what is PERT? PERT is just a fancy term that they say, okay, we have a patient who's really sick. He has a submassive or massive PE. We need all the consultants. We need vascular, we need pulmonary, we need cardiology, we need IR, we need CT surgery, we need critical care. So we need everyone. And this is class 1 recommendation from the American guidelines. Let's see. Okay, treatment. So anticoagulation is the backbone. Like every patient with VTE, they need anticoagulation. The difference is the duration only. Okay, so this is like 6 points. This is a backbone of treatment. So DOACs are the first line over warfarin. Warfarin is the worst medication ever. You will notice it on the floors when you try to discharge a patient and their INR is not on target. Sometimes they eat some stuff that will affect the absorption of warfarin, and then you won't have the INR at target the next day. You hold the discharge, and then you put them on a bridge. So it's not good. They are trying to do trials to kind of discover some other medications that can take over. But DOACs is the first line for this, unless your patient is not insured, of course. The healthcare here is very expensive, so people sometimes can only afford warfarin. Okay, so 2 DOACs, they do not need bridging. What does it mean to say that this patient needs bridging? You'll hear it a lot on the floors. What does it mean? Yeah, but what does bridging mean?
You have to start both heparin and warfarin together for the first 5 days, and then you stop the heparin and continue with the warfarin.
Yeah, that's it. So basically, you need to reach an anticoagulant steady state in the blood, right, to give you the effect that you want. But in the meantime, you need to start something that will give you the anticoagulation function. That's probably heparin or the Lovinox, which is the low molecular weight heparin. There are 2 of the DOACs. They need the parenteral lead-in or bridging, which is the dabigatran and the edoxapan. You rarely see this on the floors. I don't think we even have dabigatran, right, Dr. Vernacci? I don't think we have dabigatran. We have the Angiomax, but that's bivalirudin, I think. Yeah. Yeah. So the IV options are low molecular weight heparin and heparin. So who loves heparin? Who loves Lovinox? You like Lovinox? Okay. Who likes heparin? Well, okay, heparin is not bad, but Lovinox is the best inpatient VTE prophylaxis and treatment. Lovinox is the best studied. Like all the trials that compared both, they said Lovinox is the best, unless you have a contraindication. And what is Fondaparinux? It's heparin, right? Okay. So why do we use it? Why do we use it? Okay, there's one thing that you can use this heparin product in. Yes, yes. So if a patient comes in and with history of HIT, even if it was like 20 years ago, you won't be able to start it because of the liability stuff. This is where you go to. And there is prophylactic dose and there is therapeutic dose. It depends on what you want. When do you guys prefer heparin drip or heparin sub-Q? Whenever you have surgery or a procedure that needs like a shorter time when you stop it, so the medication can clear up from the system. Warfarin, you need bridging. The pharmacy will handle this, but that's going to be pain in your neck every day. You come to the hospital, you see, okay, what's the INR for this patient? So you have to take some time to go see the patient, say hi, examine the patients, and the patient is stable. They don't really need to be in the hospital, but they're already on the bridging. They cannot bridge themselves. Sometimes people, cannot attend appointments. So you just make sure that everything is stable before them going home. Okay, so when you want to initiate something, you go with the bleeding and procedures. What is the risk of bleeding? If I start this medication right now, what is the risk of this patient bleeding? So this is one consideration that you have to keep in your mind. What is the score that evaluates for bleeding risk? Yep. So if it's high, then you have a discussion with the patient. We think that if we start this, there's going to be bleeding, and we don't recommend it. And then you will talk about something else. What is it? What is the alternative if the patient needs anticoagulation? What is it? Yep, IVC. And then you have to check, the CBC, the platelets, the prior HIT. You need to check the creatinine to see if the patient has any kidney dysfunction and the liver function as well. And then the population, pregnancy people are different than other people, right? So what is the medication that cannot be used in pregnancy? Lovinox or heparin? No, one of them cannot be used in pregnant patients or not recommended to be used in pregnant patients. Heparin can be used, yes. Yeah, heparin can be used. You don't really use Lovinox in pregnant patients. I don't know about the safety, to be honest. I just know that I cannot use it. And then you have the cancer patients, and then you have the antiphospholipid patients. Antiphospholipid, by the way, they are a very interesting, specific population. Nothing works on them, only warfarin. Really, nothing works on them. And then you have the weight, if the patient had bariatric surgery, because all of this is going to affect the pharmacokinetics and dynamics of the medication. All right, so the DOACs, you know Eliquis. This is the most famous medication. This is the most heavily studied medication for anticoagulation, and you have the Xarelto, which is the rivaroxaban. And then you have the other two, which is the dabigatran and the edoxaban. They work by blocking factor 10. If you know the Latin or Greek letter for the number 10, it's the X. And then you have the A, which is the abbreviation for activated. So it blocks the activated factor 10, and you have a ban after it that stands for blockage. So in Eliquis, in DVT, PE, or any VTE, except for AFib, you have to start with loading dose, which is 10 milligrams BID for 7 days, and then you continue with 5 milligrams BID. What does extended means? Have you ever, guys, heard about extended anticoagulation? No? It's a new thing. So right now we're studying why do we need to be on 5 milligrams? Do we really need to be on 5 milligrams? So they did multiple trials. One of them we did in a journal club last year, and they said that you actually can be on 2.5 milligrams and have the same effect of the 5 milligrams, but only in special population. Like who? Patients who are old, patients who have kidney damage or kidney disease, and patients who are having problems with weight, or let's say underweight. Who can tell me the three requirements? You have to have 2 of 3 to be eligible to have extended therapy. What is it? Weight less than 60 kilograms. 80. And the third one, creatinine clearance less than 20. All right, so these are 3. So if you meet 2 of 3, then you are eligible for the 2.5 milligrams. What is here? Okay. Okay, so these are like special populations. Antiphospholipid syndrome, warfarin, you go for warfarin. If you have severe renal impairment, you go with heparin drip. If you have a mechanical valve, of course, you go with warfarin. All the studies that they compared warfarin to with like DOAC or something, they actually had to stop it early because of death. For some reason, I don't know why. Pregnancy, sorry, heparin cannot be used in pregnancy. You can use low molecular weight heparin. That's a mistake. Sorry. Oh, can be used both? Oh, so Dr. Hadid is saying that you can we can use both. I did not really know if we can use both. So now we're learning something new, that we can use both heparin and Lovinox. There's a certain formula of the heparin that cannot be used. And also she's saying that we have to stop at 6 hours before delivery.
But both of those can be used. Heparin has to be shut off 4 to 6 hours before delivery, and Lovinox is shut off 12 hours before delivery.
Yes.
Otherwise, it would be.
All right. So we have the therapies here. So if you see, those advanced therapies are only used in the high-risk categories, like C categories, D categories, and E categories. So if you have a patient with massive PE, category E, for example, which is the remember A, B, C, D, E, which is the last category, which is like a hypotensive, like a cardiogenic shock or obstructive shock. Then you have to use thrombolysis, which is the alteplase or tenecteplase, depend on the hospital. And then you have the second thing, which is the thrombectomy, and you have the CDT, which is actually something they go inside, they go near to the clot, and they just start administering fibrinolytics. So this is why they call it catheter-directed thrombolysis. And then you have the mechanical thrombectomy. Everyone kind of had a patient with DVT, PE, that they had a thrombectomy. And then you have surgical embolectomy. Well, this is very high-risk surgery in general. And then you have the ECMO when everything failed. Then you go to ECMO. So why ECMO? What does it do? So basically, artificial lung, sometimes artificial heart. So when you want to make the heart or the lung rest, you kind of use extracorporeal, which is like outside the body, oxygenation, and probably some people put the patients on inotropes. All right, IVC filter. 2 things I think everyone needs to know about. It's not made to stay forever. Yeah. Say again. Well, so So she's asking if we can prevent heart ischemia if the patient's on ECMO. To be honest, I'm not really expert in this question. I'm not really sure. But I mean, if I want to think about it, if the patient is having coronary artery stenosis or atherosclerosis, if the plaque just burst, so I don't know if probably the patient will have MI. This is just if I want to think about it. Sorry, that's I don't know the answer for that. Yeah, thank you for the question. All right. Yeah.
But paradoxically, can increase the risk of cardiac issue. Does it increase heart's afterload? Makes it harder for the weakened heart to pump. As such, it reduces coronary artery perfusion.
Sounds good. So this is an answer to your question. Does ECMO increase? So the question was, does ECMO increase or decrease, or can you prevent ischemic heart disease? So Dr. Jones looked it up, and the answer was it actually increases the risk of ischemic heart disease because it increases the afterload, which is going to put more strain on the heart. So the first thing you need to know about IVC filters, they should not be there forever. You have to retrieve them and start anticoagulation whenever feasible. And second thing, they prevent PEs, right? IVC filters, they prevent PEs. But what does it cause? They increase DVTs. So if the patient comes in with to you, oh, I had IVC filter, why I keep getting these? Yeah, it increases the DVT occurrence. Okay, and then we're almost there, guys. Then the second part is the interactive part. All right, so this is the duration. So I just want to kind of make it easy and simple for you guys. So we have the provoked versus unprovoked. The provoked, you do 3 to 6 months based on the situation, and then you stop after that. If it's unprovoked and you could not identify the reason, then you do 6 months. Then you try to kind of find the reason. If you do not, then they have to be on it. Some resources say indefinitely. Okay, so what's special about cancer-associated VTE? They're always at high risk, always. It's provoked, right? It's like you have cancer. So does it apply, the provoked apply to this? No, because they're always active. If they are active, if they're not in remission, they're always active. So this is where people studied, okay, now I have DVT in a patient with cancer. I treated for 3 months, 6 months. Okay, what is the effect of extending this therapy for 12 months after full treatment, but in a reduced dose? So this trial was called API-CAT. I think it was done last year, but it showed less occurrence of DVT and PE, and less GI bleed, less bleeding risk compared to the 5 milligrams and compared to the no treatment. Okay. Okay, so when discharging a patient, you always need to make sure they're safe. They know what they're taking. They know what the dosage. They know when to take it. Do they have access to it? Of course, you're gonna tell them about the side effects. If they have a bleeding, if they have altered mental status or any signs of intracranial hemorrhage or anything like that, you give them directions to or their families to direct towards. Already talked about these. Okay, so what is HIT? Heparin-induced thrombocytopenia. Same thing. It applies to it, also pre-test probability, testing, diagnosis, and treatment. Do not ever order a HIT panel without calculating the 4T score. This is one of the quality improvement projects that we're doing in this hospital. So in this hospital, we found that 70% of the orders of the head panel was unnecessary, and half of these 70%, the 4T score, which is the pre-test probability score, was 1. So you need 4 at least to send a test. If it's less than 4, don't send a test. Because it has a negative predictive value of around 99%. So if it's less than 4, it's almost 99% it's not hit. If the 4T score is 4 or more, yeah, go send a hit, because it costs the patients. So a head panel will cost the patient around $120. Some people send both the head panel and the serotonin release assay, which is the confirmation test. It costs the patient around like $450. So that's going to be like around $500, $600 for something that 99% they don't have if the 4T score is low. And the treatment is stop heparin, start other things, Angiomax, for example, and then heparin should not be resumed unless reviewed by a specialist. So this is, I'm not going to talk about. This is more about like complications of medications. And I think these are my references. So anyone has any questions? Anything that I did not really explain well?
That you brought up that recent study about extending enzyme regulation for
Yes.
malignancy, because the first question around is for like, is this provoked or unprovoked? Because that's going to tell us what we need to tell the patient in terms of expectations about being on this the anticoagulation. Was that study strictly malignancy? Because other conditions like immobility, if you're paraplegic, you may need to be on anticoagulation. You would say maybe indefinitely, because that's not a modifiable risk factor, right? If they're immobile, and that's their risk factor for DVT. Typically, we treat these patients indefinitely on anticoagulation if the has bled and is not too high. So was it just malignancy, that study, or did it just look at or provoke where you can't remove the provoke part?
So the question is, if the studies on the extended reduced dose anticoagulation with DOACs was only done on malignancy or was done on other populations. The ones I know about, all of them are on malignancy patients, like APICAT trial, Exemplify trial, like multiple trials, all of them were done on malignancy patients only. They tried multiple DOACs and they recommended 2.5 milligrams if the cancer is active. And that's after the acute treatment. So they have to have a full course of treatment, and that's going to be 12 months after the full course of treatment. So, but I think this is a new idea that they started thinking about, the 2.5. I think they are 100% studying that in other populations. Yeah. All right, guys. So this is going to be like 10 minutes. But this is nice, actually. You guys are going to be very happy with it. So I think you're going to like this. I think you're going to like this. Yeah, because this is something I built, and she likes building stuff. So this is simulation lab I built. So basically, it will give you a simulated scenario where you're on a night shift and you have a page about a patient, etc. All right, so I think we have the cards here, if you see them. Those are the teams. We have team purple, amber, blue, red, and green. So I think the red can be moved there. Like you can scooch all of these there. Everyone has to participate. All right, you guys divide yourselves. Go in. Yeah. You want to participate? All right. You want to participate? Yeah, yeah. Let's go. Everyone is welcome. Attendings, come on. Everyone is welcome. Okay, so this is the rule. It's very easy. It's not like who's gonna buzz first or like who's gonna answer first. So we're gonna tell the scenario, and like you guys will talk between each other and then answer the question. Okay, so it will take turns. So team red will have this answer, team blue will have this answer, etc. All right, so this is the first patient, Morgan Hale. So this patient is 64-year-old adult. They are here for total knee arthroplasty. So when they presented, today was day 8 after the surgery, and then they are having new unilateral cuff swelling and tenderness. All right. So you don't really have any labs on this guy. He's saturating 97% on room air. When you examine the patient, you saw new unilateral cuff. It's symptomatic, it's tender. And then in your mind, you're thinking, okay, this patient is post-surgical patient, and we are kind of concerned about DVTs, correct? Because this patient will have high probability. All right, so you guys have 30 seconds to, this is the question. All right, with high DVT, pretest probability, and proximal compression ultrasound available now, what is the best initial test? You do a D-dimer alone, you do proximal compression ultrasound now, you do CT pulmonary angiography, or no testing because post-op swelling is expected.
Yeah, but was the patient post-op DVT performed?
No. It happens, Doctor. Remember, he is already high probability. All ready? Everyone ready? Okay. Team blue. What's the answer? Okay. Lock it. Lock it. Okay. Team green. There. B. B. Okay. Okay. Team purple. B. Okay. And team amber. B. All right. Okay. Team red. All right. Okay. Ready, guys? Okay. You're right. So, okay, nice. So it's B. This patient is already high probability, right? So you go directly to imaging. All right. So let's say you did the ultrasound and the initial ultrasound is negative. All right. The image quality is adequate. Symptoms persist and pretest probability remains high with no alternative diagnosis. What is the best next step? 30 seconds. So the first answer is declare DVT excluded after this single proximal study. B, order a D-dimer and stop if it's below the usual cutoff. C, arrange repeat proximal compression ultrasound in 5 to 7 days. And give symptomatic thrombolysis for presumed DVT. Okay, time's up. Team red. Team red. D. Okay. Lock it. Okay. Team blue. D. Okay. Lock it or no? D. Okay. Team green. C. All right. Team purple. B. B. Okay. All right. Team amber. C. All right. C. Let's go. Good job. All right. So, so basically, if you have high suspicion and your initial study is negative, you still have to do another one to rule it out. Okay. All right. So let's say we did. It was C. Yes.
5 or 7 days. That's what.
No, it's not. No. You wait for 5 to 7 days. Yes, that's per the guidelines. Mhm. That's why. No. It's in general. Even if if the initial study is negative and there's only symptoms. You don't treat. You don't presume it's DVT, and then you wait for 5 to 7 days or sooner if the symptoms are worsening. Then you do another ultrasound to 100% rule it out. All right. So for this patient, they repeat the ultrasound, and that repeat in 5 days shows acute femoral DVT. All right. So the patient is not bleeding. Surgical hemostasis is secure. The creatinine clearance is 55. There's no cancer. The patient is not pregnant. No lactation. There's no other medications, and there is no medication access barrier. What is the best treatment plan? Arthroplasty, knee surgery. All right, time's up. Team amber. Hey, okay, lock it. Team red. Team red. Hey, nice. All right, team blue. Hey, team green. Okay, team purple. All right. That's correct. Good job. All right. So this is your score. So we have green and amber in the lead. And then we have blue, purple, and red. Okay, so we can stop here if you want, or we can continue. It's up to you guys. Okay. All right. All right, guys. So this is the last case we're going to do. And after that, you're good to go. All right. So this patient, Avery Brooks, she is 64-year-old female. She is presenting with acute decompensated respiratory failure. And so dyspnea, pleuritic chest pain, and you are concerned about pulmonary embolism. And then you want to evaluate. There is no really labs. They just told you about this. And your pretest probability is around 20%. So it's intermediate to low. You don't really have a D-dimer. So, and your creatinine clearance is 82. All right. So using a conventional regular scoring or probability system plus age-adjusted D-dimer, we're going to talk about it. What is the best initial test? Is it CTPE without obtaining D-dimer? Is it D-dimer? Is it you just exclude PE because the patient is looking fine? or you do a lower extremity ultrasound to see if there's DVT. Dr. Ramsakal is someone. Okay, time's up. Team Purple. You guys are up.
If that's the case, then I think
A? All right, lock it. All right, Team Amber. B? All right. Team Red. All right. B? All right. Blue? Where's blue? B? All right. Last team, green? B? All right. That's true. B is the correct answer. All right, so you did the D-dimer. So the results come back. It's 720, and your age-adjusted D-dimer, this is the highly important point here. If a patient is older than 50 years old, you do an adjusted D-dimer. It's the age times 10. So this patient is 62, and their cutoff should be 620. All right? Their D-dimer is 720. So what do you do next? You exclude it, the PE. You repeat the D-dimer tomorrow. You proceed with CTPE, or you use ultrasound to see if there's any lower extremity thrombosis. All right, time's up. Green. What is it?
How old is she?
62, 64, 64. C. All right. Team Purple. C. Team Amber. All right. Team Red. All right. Team Blue. Nice. All right. C is the answer. Good job, guys. Nice. All right. Last question. So you did a CTPE, and it confirms a segmental PE. So the category is B2. It's like really the patient hemodynamics are fine. She's not on oxygen or anything like that. So the low severity, that's what they consider the PE to be. No RV strain, negative biomarkers, no hypoxia, hypoxemia, or organ hypoperfusion. So what is next? Discharge on aspirin, give routine thrombolysis and admit to ICU, start anticoagulation, oral anticoagulation based on the guidelines, or withhold anticoagulation because the vital signs are normal. Well, one tip for any exam taking, always go with the longest answer. Because I did not really, I'm not going to waste my time writing an incorrect answer that long. All right, so everyone will choose C at this point. All right, so I'm just going to have two winners today because I think our time's up. So Team Green and Amber, let's go. Let's give them an applause. All right. So that's it for me, guys. If you have any questions, I'll be happy to answer. Good luck. Of course. Of course, guys. You take care.
Wonderful presentation.
Oh, thank you. Thank you. Appreciate it. Thanks, man. No, no, it's okay. Sorry. Thank you.